This video has been funded through an educational grant from Biocon Biologics Limited. Biocon Biologics Limited has no input towards the content of the interview or the video. The European Society for Medical Oncology, or ESMO, Congress was held in Barcelona, Spain on September 13th to 17th, 2024, and included 269 sessions and 2,186 abstracts. Its comprehensive program encompassed potentially practice-changing presentations that highlighted advances in translational cancer science and fostered multidisciplinary discussions. Professor Dirk Arnold spoke with Karger following the conference to reflect on the presentations and practice-changing information given at the conference for colorectal cancer patients and healthcare professionals.
Well, ESMO 2024 has been an extremely successful conference. It have been more than 34,000 attendees, nearly 600 speakers, and the level of interaction has really been great. Let's say the discussion of new data, putting them into context with older and existing data, and finding good solutions for patients with advanced stage disease and drug treatment, as well as interdisciplinary treatment, has been really great. What is clearly relevant, like in all other tumor types, is the different role of ctDNA. And we have learned mostly at this year's ASCO meeting that for early stage determination of minimal residual disease of patients with localized colon and localized rectal cancer, the ctDNA MRD, so minimal residual disease positivity or negativity, seems to be a strong predictor of patients' prognosis and or likelihood to have a relapse of this disease or not. So this is really outstanding because many trials now use this as a kind of stratification part for intensifying or de-intensifying post-operative chemotherapy. And this will maybe also help us in the preoperative setting to see whether we do a successful neoadjuvant treatment or not. And next to this, and this has also been, let's say, shown in a trial which has been presented at this year's ESMO meeting, the, let's say, molecular control of the disease, we'll say the eradication of a specifically a RAS mutant clone can be the way how to direct and how to initiate a treatment or not. And they have done this in a randomized trial in late line setting where ctDNA-based definition of RAS mutation and RAS mutation disappearance or persistence, and then the randomization to, dependent from that, either anti-EGFR treatment or whatever standard of care investigator chosen, has shown us that the ctDNA-based or ctDNA-stratified reintroduction of the anti-EGFR is beneficial. So therefore, next to the MRD situation, the monitoring of the disease and then the adaptation of the treatment according to ctDNA profile, I think these are the main drivers for many research questions and maybe also for the very soon for the clinical routine.
What are some of the themes from this year's conference in colorectal cancer treatment?
Well, we are continuously improving. And of course, fields do differ. And some tumor types clearly have the big boom, having new drugs or new therapeutic principles entering the field, we'll say. Some really advanced stage immunotherapies like T-cell treatments, like in melanoma and other renal cell cancers have entered the arena over the last years, whereas in the most of solid tumors, immune checkpoint inhibitors in various combinations have consolidated the findings from about 10 years ago when they entered this field. But most of this, despite that all benefits of in whatever tumor types, in most tumor types, there has been an increment in knowledge, an increment in use of these drugs, and also an increment in understanding the mechanisms and how to best use and how to combine these drugs.
What place is immunotherapy taking in selecting treatments for eligible patients?
Well, when it comes to immunotherapy, it's clearly about combination and it's about biomarker detection, which combination should be used in which patient. And without going to too much detail, and we have seen massive improvements, for example, in bladder cancer as well as in breast cancer and also gastric cancer and other gastrointestinal cancers. But without being too much in detail, I think the key is really that we start to understand which patient may be benefiting from this general principle. And that these findings and these markers, which indicate sensitive patients, are not only related to the standard immunomarkers, but also may be found in the profile of cell-free tumor DNA and others. So therefore, the better understanding identifies a better proportion of patients with the utmost maximal benefit.
Are there any new insights into biomarkers for selecting treatment types or timing?
The field of MSI-high colon and rectal cancer being only locally spread and non-metastatic is really evolving. And somehow surprisingly, when compared to treatment of metastatic disease, where these drugs also wonderfully do work, but compared to the metastatic stages, the efficacy in local stages seems to be way higher. We haven't completely understood why this is the case. Maybe the immune regulation in the metastatic sites is different and also differs between the metastatic sites, lung and liver, or lung versus liver, versus primary tumor. But the responses which we do see in primary tumors are excellent. And this has been shown in rectal cancer with single agent dostarlimab, with achieving clinical responses in many patients, which really has its clinical use and its clinical benefit, and here these updates from ESMO 2024 are important, has also been shown in localized colon cancer, and here for the immunocombinations more than for monotherapy. And in fact, we have been seeing data from the Dutch niche trial platform. This is a platform of now 3 trials and more to come, which is examining a localized MSI-high colon cancers, various combinations, and the Nivo-EP combination from the niche 2 trial is the one we do now for 2 years. An update has been presented that none of these more than 100 patients which underwent treatment with this checkpoint inhibitor combination and then underwent resection has progressed to date. So I would say there is 100% disease-free survival rate at 3 years, which is really outstanding, but also not surprising because it nicely correlates with the already seen excellent high rate of pathological response. So nearly 7 out of 10 patients had a pathological complete response when the tumor was resected, and nearly all patients had at least a pathological response at all when the tumor was resected. So therefore, it's not surprising that these tumors, which were dead when they were resected, lead to a good life without any relapse. And the same was seen in the niche 3 trial, not such a long follow-up, but a different combination, nivolumab plus an anti-LAG-3 antibody. And this also produced nearly superimposable responses, pathological responses. So therefore, the key message is very short time treatment duration with immunocombinations are very efficacious and lead to a high rate of pathological response. And this may be translating in disease-free survival. Key question is really what to do with these tumors. When we treat these patients, can we believe that these patients will not progress or will not relapse if we would leave the primary tumor in situ without any operation, just trust on the clinical response? And here, interesting and maybe mind-stimulating or clearly mind-stimulating reports have been coming out in niche 2 trial looking on ctDNA and a correlation with ctDNA decrease during this short treatment phase of 6 weeks of the preoperative treatment, and then the correlation with the pathological response. So maybe additional markers like this biomarker ctDNA may help us to define in future a patient group which is that sensitive that we can believe that this is a stable and robust pathological response, and these patients may maybe not be in need for resection of the primary tumor. And we have also seen some more data from the trial from the MD Anderson Cancer Center in rectal cancer, as well as from the French collaborative group, the Imhotep trial. These trials have been using single agent checkpoint inhibitors, pembrolizumab, and also pathological responses are detected here. But however, it seems that the combination immunotherapy leads to higher rates of pathological responses than single agent treatment. And also, single agent treatment has to be given longer. The combination has also only been given in the niche platform for 6 or 8 weeks, whereas treatment in the other trials is longer, up to half a year. And also, the treatment duration with single agent correlates with the rate of pathological complete responses. We'll say longer treatment seems to be beneficial for single agent, whereas for combination, a very short treatment time should be likely enough.
How does treatment tolerability differ across those options?
Right, that's really the aspect, and that's the trade-off we have to do, since we have learned that combinations cause more immune-related toxicities than single-agent treatments, but also treatment duration and toxicity over time is really an important aspect to consider. So I would say, for the moment being, we cannot say what is really the best process here or the best procedure here. Single agent is really a safe way to move forward. However, maybe in specific neoadjuvant settings, we'll say bulky disease, T4 tumors, etc., it makes more sense, despite the higher risk for toxicity, that combinations may be preferred. But these algorithms, treatment duration, treatment intensity, and the clinical outcome, and then the clinical consequences, have to still be put into context. And I think that's what we will be learning also in the future.
What insights can be shared in targeted therapies for colorectal cancer from different diseases?
Well, the interesting thing about these targeted approaches in colon cancer is that they have been tested in relatively late stage metastatic disease, and they still worked in pre-treated patients. And what we have seen this year is, for various targeted approaches, be it KRAS G12C inhibitors, be it BRAF inhibitors and others, that also these drugs being put into first line as add-on to standard chemotherapy plus bevacizumab or plus an anti-EGF receptor antibody seems to improve the outcome. Of course, we have to be cautious. That's single agent, relatively small scale trials. But we have seen impressive rates of tumor burden decrease and impressive waterfall plots. And specifically for HER2, that's the bispecific antibody zanidatamab, which has been examined in a 2-cohort trial in combination with standard chemotherapy with and without bevacizumab. So nearly all patients massively responded, and therefore, for all of these approaches, they still have to be proven in randomized trials and with a higher level of trial evidence. But the results are really stimulating and are really promising. So maybe the best way for these drugs is really, which I personally wouldn't have thought, in first-line combination with standard chemotherapy plus monoclonal antibody.
What options are there in designing trials to meet the profiles of individual patients or tumors?
Well, there are so many ideas about intelligent trial design with adaptive designs, with also synthetic control arms, with shared control arms across different trials, etc. Unfortunately, our fantasy is not the only thing which really counts here. Also, legislation and registration agencies do have to, let's say, speak a word here. So therefore, we are somehow limited in the freedom of our creativity. But we can clearly see that it makes sense to also look on these combinations in early treatment lines. And we are also happy to see that other endpoints really also add to the overall evidence which we do gain. It's not necessarily looking on time to event parameters like progression-free survival or objective response rates. It's also ctDNA level decrease, eradication of whatever molecular clone via ctDNA, etc. All of these rather lab or synthetic or artificial, whatever, outcome parameters tell us something about the biology which is happening here, the effective biology or the modification tumor biology which is happening here. And for example, if you have a specific mutation, and if you see this clone with a specific mutation being eradicated as a result of a first-line combination treatment, that's a great thing. Yeah, we still have to see how this translates into time to event parameters, but per se, that's already a strong signal.
Tell us about the Podium 103 trial covered in your conference session.
Well, Podium is really something new because it addresses a disease where we hardly had any phase 3 data, and now we have a phase 3 clinical trial result, which which clearly will have an impact on the definition of the standard of care. So Podium is a large 308 patient trial which randomized between standard chemotherapy and standard chemotherapy plus a checkpoint inhibitor in patients with metastatic anal carcinoma. Anal carcinoma is a squamous cell carcinoma. It's different than adenocarcinoma from the colon and from the rectum. And the standard of care in this rare disease, and that's really by terminology a rare disease, has been a double combination of carboplatin plus paclitaxel. And an independent scientific collaborative group from the United States, United Kingdom, many European countries were looking out for having this standard chemotherapy being combined with a checkpoint inhibitor. So two different pharmaceutical companies helped us, and here we report the result of the first of these two trials, which is from Europe and Asia, non-US sites, randomizing between the standard chemotherapy carboplatin paclitaxel plus minus retifanlimab, which is a PD-1 inhibitor, and progression-free survival as primary endpoint has been significantly improved, and also did overall survival. And this is of note, overall survival, although not being statistically significant, but nearly. And this despite the fact that nearly 50% of all patients crossed over, we'll say, after they were progressive under the standard chemotherapy plus placebo, so we'll say without the anti-PD-1 antibody, they were then entering the trial with anti-PD-1 as single agent. And despite that, the trial was nearly statistically significant. More follow-up is needed, more follow-up will come, not many events are present, but this shows how massive this benefit by adding the checkpoint inhibitor is and how important this is for these patients with their poor prognosis. And we have seen that numerically, median overall survival likelihood is more than half a year longer. So I think the signals are clear. Hazard ratio is 0.17. That's also a strong signal. However, these are relatively small trials given the rare cancer situation. So therefore, if this would be a massive trial with many hundred patients, this would be already positive now. But here I'm sure that longer follow-up will lead us also to, let's say, the statistical significant positive endpoint in this secondary endpoint.
In summary, what is practice-changing for professionals? What is life-changing for patients?
Well, I'd say there are three aspects. The first is a clear takeaway for tomorrow is the addition of checkpoint inhibitors to anal cancer first-line treatment. The second is in the MSI high population, if patients are no good candidates for surgery because they cannot do this for comorbidity, or if they have a low-lying rectal tumor, which would then prompt into amputation of the rectum, I would say that in these patients, it's clearly today to justify the treatment with checkpoint inhibitors. And that's already in many national guidelines for rectal cancer and also ESMO guidelines, which will be, let's say, being published later this year. This will be a recommendation also there to follow this route. So that's really having implication. Out of these new approaches, we have seen that the integration of other drugs into first-line setting will be coming. So I would not be surprised to see an anti-HER2 or G12C KRAS mutation inhibitor in first line. And then I will say the first time when we saw this was at ESMO 2024. And we have also learned that maybe another interesting drug, amivantamab, may be entering the field of colon and rectal cancer. So amivantamab as a bispecific antibody, anti-EGFR, anti-MED. Results have been reported from a randomized phase 2 trial in second line, and the efficacy of this second line treatment is really outstanding. So response rates of nearly 50% for patients being treated with chemotherapy plus plus amivantamab. That's also stimulating. This will prompt in a relatively soon starting phase 3 trial in first and second line. So this will be, let's say, the most important immediate consequence out of this early data.